Welcome.
The Pathology Innovation Collaborative Community is a regulatory science initiative that aims to facilitate innovations in pathology, as well as advance safety and effectiveness evaluation. The PI Collaborative Community aims to harmonize approaches to speed delivery to patients through collaboration in the pre-competitive space. The PI-CC is open to all stakeholders, public or private, including but not limited to academia, industry, healthcare providers, patients, and advocacy groups. Meetings of this kind are an example of lawful activity under federal antitrust law, because the focus of the meeting is on government action or policy, including the industry's responses or positions taken with respect thereto. However, antitrust monitoring is needed for companies' own protection, since they are direct competitors meeting together. These meetings need to stay within protected subject matters and need to be monitored so that they do not stray off into inappropriate areas, such as pricing and price terms, sales and service territories for particular products, customers and customer territories, each company's individual decisions regarding selection of suppliers or customers, marketing plans and especially future marketing plans or new product offerings, other proprietary or competitively sensitive information. Today's meeting will follow the written agenda, and there will be no discussion of pricing or other prohibited topics. If the discussion veers into those topics, we will terminate the discussion. If you have any questions or concerns about the propriety of a discussion, please raise it immediately, and we will take a break to determine how best to proceed. The Medical Device Innovation Consortium acts as the formal convener, and we will follow their conflict of interest policy. For additional information, we defer to our Code of Conduct and our website, www.pathologyinnovationcc.org. We look forward to moving the field forward.
All right, we get started, and before we switch over to Dr. Gallas, Brandon, I wanted to say a few words about who's organizing this. So we're the Pathology Innovation Collaborative Community, PICC for short. You can find us at pathologyinnovationcc.org. If you haven't been there, the group can be joined for free. No ties, you can also leave at any time, but we would of course love if you join, because there's a lot of free and informative material, just like this session today. So if you are on the website on the top right, you can join, and if you represent a company, an entity, or a sector of industry, a patient representative or professional society, you can also join and put your symbol and links onto our landing page. Briefly, what is a collaborative community? We are a so-called regulatory science initiative. We want to facilitate innovation in a broad range of pathology devices and diagnostics. And we do this by trying to harmonize many different approaches to speed delivery to patients. We act in a pre-competitive space, and I hope that Ulla can paste our rules of engagement so antitrust monitoring fully applies. And we're open to all stakeholders. As you see today, I think there will be eventually about 100 people on the call today, and this is open. And as a platform, this slide is providing a quick overview that if you're interested in this space and you value collaborations, you can propose projects, and we host these, just like this session, to serve the community and move the field forward. We do not engage in competitive product development, and we do not really actively influence one or another project. So if you have a need for such an infrastructure or value collaboration, please make use of that. So without further ado, Brandon, it's my pleasure that we have you here today and talking about a topic that is very much of interest to everyone. Brandon, with that, I hand it over, and I'm very excited about this session. Thank you.
All right, let me verify you can see my screen.
We can see the slide, but not the presenter's view. Yes, but...
All right, yes, that's my little cartoon to
perfect.
Relax everybody for this talk. I hope it's everybody enjoys it. I'm going to ask for questions to be put in the chat for the end because I want to get through a lot of material. And actually, to kick things off, I'm going to start with a version that was already recorded.
And here we go. Hi, I'm Brandon Gallas, and I work in the FDA Center for Devices and Radiological Health. I'm in the Division of Imaging, Diagnostics, and Software Reliability in the Research Office of Science and Engineering Laboratories. In this video, I'm going to give a graphical tutorial on ROC curves. Imagine a clinical scoring rubric, diagnostic device, or artificial intelligence model that produces scores from a population of patients that yields these two distributions, one for cases with cancer and the other for cases without cancer. This situation would be great. We would be able to make perfect decisions all the time. Let me explain. First, we drop a threshold between the two distributions, and we're going to focus just on the clinical decision. When we evaluate a case with our diagnostic test and get a score above the threshold, we make a positive call. When we evaluate a case with our diagnostic test and get a score below the threshold, we make a negative call. Looking at the decisions and the case distributions, we see that we would make correct or true positive calls on all the diseased cases that are truly positive for cancer, and we would make correct or true negative call on all the cases that are truly negative for cancer. Unfortunately, the real world is more complicated, and the distribution of scores on the cancer cases overlaps with the distribution of scores on the non-cancer cases. Let's add a threshold and summarize what we see in the distributions in ROC space. In this example, we see that we will make positive calls on half the cancer cases. These are correct calls or true positive calls. Averaged over the cancer cases, we get a true positive fraction, TPF. The TPF is also known as sensitivity. Looking at the distribution of non-cancer cases, we will make positive calls on a small fraction of these cases. These are mistakes or false alarms, because we are making a positive call on a case that doesn't have cancer. The rate of false alarm is also known as false positive fraction, or FPF, and 1 minus FPF is known as specificity. Now we can summarize what we see in the distributions with an operating point in ROC space. The TPF is 0.5 and the FPF is 0.1. If we move the threshold a little to the left, we will make more positive calls. This will increase the true positive fraction at the cost of an increase in the false positive fraction. In this example, sensitivity is equal to specificity and the point is on the negative diagonal. We can move the threshold a little more to the left and increase our sensitivity even more, increasing the false positive fraction to 0.5 and adding another point to ROC space. Each of the different thresholds gives a different point in ROC space. As we lower our threshold for decision making, we are being more aggressive at calling cases as cancer. The best operating point is beyond the scope of this tutorial but can be investigated. Such an investigation is referred to as a risk-benefit or cost-benefit analysis. At the heart of these analysis methods are risks and costs of each kind of decision. In medical imaging, where the diagnostic scores may come from radiologists or pathologists, it's appropriate to consider all thresholds. We can sweep the threshold from right to left or left to right to fill out an entire ROC curve. In this graphic, the ROC curve is nice and smooth. Real data will yield an empirical ROC curve that has discrete steps. Modeling real data will return an ROC curve that is, again, nice and smooth. The area under the ROC curve is a summary index of the diagnostic capacity of the diagnostic score. In my last slide, we explore the amount of separation between the diagnostic scores from cancer cases and non-cancer cases. At the bottom there are two distributions that completely overlap each other. The diagnostic score is unable to separate cancer cases from non-cancer cases. The diagnostic score is just a random guess, and it yields this chance line. Imagine for every threshold, the true positive fraction will equal the false positive fraction. The corresponding ROC curve is the diagonal line, the chance line, and the AUC is 0.5. In the middle, the two distributions overlap considerably, and we get some moderate diagnostic ability shown by this middle curve. The AUC for this curve is somewhere between 0.7 and 0.8. Finally, at the top, these two distributions are quite separate, with very little overlap. The AUC for this curve is about 0.9. So you can see here that the AUC ranges from 0.5 to 1. It ranges from the diagonal line to the curve that contains the entire ROC space. The diagnostic capacity of the diagnostic score is driven by reader skill and the capacity of the technology. How well the technology can identify the disease. Every task, every combination of technology and cases and readers has a diagnostic capacity. We can increase that diagnostic capacity by improving reader skill or improving the technology. Well, that's the end of my talk. Thank you for listening.
All right, thanks for putting up with that quick tutorial. Let me hide this meeting control. But I wanted to make sure everyone's coming in with a basic understanding of the area under the ROC curve. And I promise I'm live from this point on. And I'm happy to be here. And Joe, I'm really thankful that you invited me. Hopefully I wasn't insulting anyone with such a basic tutorial. But you know, we have to start with something very basic, and this audience is pretty broad, as Joe said, and I wanted to make sure we all started on some kind of level playing field. Well, the other Brandon introduced himself. I'm in the research arm of the Center for Devices, and so we do research to support the evaluation of the devices that come to the center, but also to create tools and methodologies that will then maybe lead to more efficient and better methodologies for evaluating devices. And that's what this is about. This Mrmc analysis is something that happens for reader study designs, and I'm going to define all of these words in the next moments. You know, first I want to make sure that nothing I say is official guidance, or none of the devices I might mention is support or endorsement of those devices, just as a way to get started. Well, it looks like my cartoons make it into my slide deck, so let's get started though. It's going to really go from the reader studies and definitions to some of the math, and I'm sorry I have a little error here. It should show a picture of the equation. Down here is going to be something related to study designs and simulations, and then I'm going to show you a real example. Sorry for the interruption on these cartoons that were at last minute to add a little bit of personality here. Anyhow, so what are reader studies? Reader studies are studies with the human in the loop. We also sometimes refer to them as clinical performance studies because they're showing the performance of a medical imaging device when the human is actually using them, not just standalone performance with like an algorithm that is giving you diagnostic scores. Those scores typically need to be interpreted by the human, and that's what I mean by human in the loop. They are looking at the images, they are receiving the information, and they are providing the diagnostic decision scores. So most often we see this for comparing the performance of a new imaging system to a reference imaging system. Back in the day, and where a lot of this work is based on, was the evaluation of digital mammography, full field digital mammography, and comparing it to the technology that I don't even know if it exists anywhere, screen film and mammography. Or you can also think of comparing whole slide imaging to the microscope. Whole slide imaging is when you digitize glass slides and you make your diagnostic decisions using a monitor rather than a microscope. What I see day in and day out are studies that compare the human without an aid, a computer aid, an algorithm, artificial intelligence, and then comparing them with some sort of software as a medical device. And then the last, that's kind of things I've seen in radiology. Our group reviews all of these kinds of devices. This one about new reconstruction methods that are using artificial intelligence as well. I like to break down the reader study into these other components as well. Task performance, detection, classification are very different from grading and measuring. And so you really want to know what is the task to be performed, because that's going to specify and direct you to the performance metrics. It's also important to identify who are the readers for this task. Is it a clinician or psychology student or a radiologist or a pathologist that is performing the task? And then finally, and this is probably paramount at the FDA, is knowing the patients that are in the study. That's very important to always identify the clinical population, and because we want to make sure that those are well represented in the study. What I forgot on this slide is the truth. Where's the gold standard? Where is it coming from? That is one of the most overlooked items and something that I spend a lot of time thinking about. And just so you understand the language at the FDA, most people want to say truth. Most people want to say gold standard, but at the FDA, most of the time, these things have uncertainty associated with them. And when they have uncertainty associated with them, we refer to them as a reference standard rather than the gold standard. There's a few gold standards out there. Outcomes are often the best gold standard. Death, it's hard to think of uncertainty in death, or one person thinking the person is death and another person not. Those are pretty solid outcomes for the reference standard or the truth. But just so you know, this is a challenging topic always, determining the truth. For example, outcomes, I just gave you some example. Some other examples might be follow-up. In radiology, pathology, in biopsies are the reference standard. But more and more, and especially for things that are not so outcome driven, is using expert panels to determine the reference standard. And a lot of my research right now is in that area. All right, I like to break down the performance assessment into groups according to the data and the task. So the data and the tasks are really drive what performance metrics to use. We did the tutorial on sensitivity, specificity, and the area under the ROC curve. So I won't belabor that. But these quantitative data, measurements, quantitative values, grading system, scoring systems, they have to have completely different kind of metrics. Sometimes you might be able to use mean squared error and correlation. Limits of agreement and Bland-Altman plots are another thing when you have quantitative measurements. And there's probably another class out there of qualitative scores or qualitative categories, and that also is different. The Mrmc analysis, when I use that language, I mean analysis. You can talk about an Mrmc data set. That's a data set that has multiple readers and multiple cases. But the analysis is really about accounting for reader and case variability. When I use Mrmc analysis, that's what I mean. I am accounting for the reader variability and the correlations that result in the data set from how the data is collected. We're going to talk about some of those study designs, and a very common one is when every reader reads every case, and we refer to that as the fully crossed study. But you can imagine there's a lot of correlations because every reader is reading this exact same cases. That's the correlation structure of that study design. The analysis methods, when I use the word analysis, we're going to talk about estimating variance, estimating confidence intervals, doing the performance test. And the whole point of accounting for these sources of variability is that we want our results to generalize to the population of readers and cases out in the rest of the community, in the real world. And you hopefully have already got the picture here that readers are clinicians, cases are the patients or the patient images. And everyone is comfortable with it. There's always this pivotal study that's going to happen, that's going to be what you publish, it's going to drive decision making. And I want to give Wei-Ji Chen some credit on this slide because it really hits the heart of things. We love to see the performance result in the end, and delta A you see here is the performance of the new device compared to the old device. You see a couple of variances there for the reader and the variance for the cases. Those are performance, those are the parameters that are coming from the data that allow us to capture the confidence interval on the area under the ROC curve or the difference. And but there's a lot more that goes on. This is obviously what gets the highlights and the publications and the attention, but there's so much more work that goes on in the background. And there's all the preparing for the pilot study. And one of the biggest questions I get is, well, how big does my study need to be? And that is the golden question of always. And it's not an easy question. It takes actually a lot of work up front. These pivotal studies of similar systems or a pilot study with your device is really the only way I know how to really get started in this problem, because we need some sort of estimate of the performance. That's kind of normal. We see that all the time. We assume some performance. But what we really need here is an estimate of the variance components, because every task has a different level of performance. Every task has a different level of uncertainty that arises from the readers. And there's some sort of distribution of case difficulty from the cases. And all those things are part of the groundwork to size a study. And ultimately, it takes a little bit of experience and art to select these parameters and tweak them, and while also accounting for practical issues of where are these slides going to come from, where are the patients going to be recruited. All that stuff is a balancing act between the statistical considerations and the practical considerations in order to size your study. So that is no easy topic, but I'm going to address some of that here today. All right, time check. Doing all right. So data collection, I'm just going to give you a little example of a study I did, and I did the data collection in 2 steps. The first step was the patient management decision. I like to start with something that the clinician is comfortable with, and they are comfortable making binary decisions on what to do with the patient. But as a technology assessment, my goal is to get a little bit more information, because binary decisions are fraught with the human level of aggressiveness, as you saw on that ROC analysis. And we'll see a little bit more of that later. So here is a case report form, a digital case report form that we used for the study that I will show later. The first question here being, would you recall this patient? They were looking at digital or screen film mammography images. And in this case, I'm demonstrating that the radiologist said no, they would not recall the patient because it's normal imaging. And but then I want more information. So I remind them of some of the instructions for giving me more information. And then I ask them to make a tick mark on this scoring system. It goes from 1 to 100, 1 being the most normal patient they've ever seen, and 100 being the least, being right near the threshold for maybe calling that patient disease. But since some people want to actually give it a number, want to have that real strong control, and there's also an opportunity to type their score into that box. And then there's the opportunity to make a signal to recall the patient, give a yes to that binary decision, in which case there's maybe some different instructions for the radiologist in how to use the high level scoring system down here. Again, they're going to put a tick mark somewhere between least suspicious and most suspicious. And then we're going to put those 2 scales next to each other to have an entire, not so much continuum, but pretty close to a continuum of a decision score with a decision threshold built into the data collection strategy. You kind of hopefully already get the feeling that providing written instructions to your participants is important. I like to give the participants comfort in what they normally do. That's the idea of the patient, making those patient management decisions first. I like to let them know that we're not evaluating them, we are evaluating the technology. So, and I'm going to be asking them for information that they're not used to giving me, these scores down here. And that's why you have to give them instructions on how to do that scoring, because it's kind of foreign to them. I provide a rubric for them to think of to do that scoring. I tend to stay away from probabilities. Probabilities have so much baggage, and we really are not very good as humans understanding probabilities on a case-by-case basis. We can certainly understand what it means, but when we're scoring things, there's a lot of baggage that goes into from training on what to expect in terms of these probabilities. The ultimate goal in an ROC study is to rank each patient. If I had my way, we would have a big old conference room table and all the images that could move around to create a pile from the left to the right where every one of those images is ranked. They could look at both of them side by side to fulfill that ranking. By the way, this case report form and scoring instructions are on the web. There's a bunch of stuff I share on the web. I try and share everything, and you can use these resources at your leisure. Sorry about my last minute addition of those cartoons. Do not help me with my bouncing from section to section. But here, the next section is about variance components. And I promise you, this is going to be a one equation talk. I'm a mathematician. I like equations, but I don't want to distract everybody with equations. There's basically three random effects when we're talking about these ROC studies, these MRMC studies. The first random effect is coming from the case variability, and we have a population of non-diseased cases and a population of diseased cases. And then when you compare them side by side, there's some sort of interaction between them happening. There's also reader variability. And then there's another interaction term that is related to the reader in the case, and there's three groups of those as well. And this is what the equation looks like. Here's that term related to the non-diseased cases and the diseased cases, and the interaction term, a reader variability, and then three more components. We can use different methods to estimate the AUC, but if we use a non-parametric method, this is an exact equation. This is not a model. This is the components that you get. Of course, if you did modeling, there's still, you could put this variance model on top of it and understand that the variance does break down into these basic components. There's 7 variance components in the numerators. These are population quantities. If you collect more data, you're just going to get better estimates of these individual components. If you collect more data, the denominators are what are going to get bigger, so that the variance contribution will get smaller. So that decomposition between the variance components and the coefficients that come from the experiment size is a nice tool to allow us to, once we estimate these variance components, we can start exploring the size of the study. And this is where the whole sizing of the study starts with, is we get the components, we start exploring different numbers in these of the experiment size to see what the trade-offs will be with respect to the size of the experiment and the overall variance that we will get. I think I said all these things. Here I've switched to the equation to be 2 modalities, so I hope I don't get charged for another equation. It's exactly the same equation, just we have to interpret the variance components a little bit differently. Instead of being the variance components of one AUC, it's the variance components of the difference. Hope that is not a problem. And like I said about the sizing, we can start playing with the N zeros, the number of non-disease cases, the number of readers, and so on. And I'm going to exemplify that right here. This is a colposcopy study, not my data. It was a small study to start with. And you can see the variance result. That's what the y-axis is. It's telling us the variance from our study. The x-axis is the total number of cases, and I think there were 30, it looks like there were 10 signal present and 10 signal absent cases in this study. And the goal now, as we go to a pivotal study from the pilot study, is to reduce the variance by 50%. And that's where this orange line here is half of where our pilot study variance was. And if we consider a couple strategies for adding more data, we could collect data at a 1-to-1 ratio of signal present to signal absent. We can consider the natural prevalence of this disease, at least in this subpopulation, that as far as I understand, the ratio being 4-to-1. We could also add just non-disease cases or just disease cases. And we're going to see all 4 of these strategies play out as a function. We're using the equation we just saw by changing this number of cases and readers. So if we add cases at a case mix of 1-to-1, that's this bottom line here as we go on. That seems to be pretty effective at reducing the variance. It gets to that 50% point the fastest, and it seems to be below all the others. If we add cases at the case mix of 4-to-1, we get a similar rate of decrease of the variance. So that seems pretty good too, if we wanted to try and honor the prevalence in the clinical population. If we only add diseased cases, that seemed to get us down to our goal, our target variance, but it took longer, it took more cases to do that. And if we only add non-diseased cases, we actually will never get to this line. And the reason is, in the equations we saw before, by adding one population only, we're sending some of those components to 0, but the others will remain. So by only adding non-diseased cases, we're not reducing the variance from diseased cases. And we're also, in none of these, are we reducing the variance from the readers. We would have to add more readers to decrease the variance component for the readers. All right, and all this stuff, the methodologies and the frameworks have been published. I also have software that is being shared on GitHub. Google Code retired their whole system, so we moved to GitHub. It's been a great place for us, but it's also on CRAN, which is a repository for R packages. R is a statistical analysis package. And here are the links to all those software. There's certainly other software out there, but this is my talk, so I'm highlighting my software for the time being. If you do some searches on Google for MRMC, I'm sure you'll find the literature that's out there in this space. All right. So I'm not going to spend any time on simulation discussion because I just don't have the time today. But you can imagine for statisticians, simulation is the method, the tool that we use to validate our methods. And I have published methodologies for simulating binary data, multiple reader, multiple case binary data. And what's nice is the simulation methods in these papers actually have analytical results, so we know what the answers should be from the simulation. But anyhow, I don't have time today to go into that. But those slides will be in the slide deck that I shared. And I guess this is a handy way to share the cartoon at least, and you can look at it later. I think I want to make sure we are sticking to the time, and I want to get to study designs. So these are cartoons of how I like to think of the data. I'm going to go into these in a little more detail. I already mentioned the idea of a fully cross study. That's where all readers read all the cases. And the readers are paired across the two modalities. When you look at these two pictures, you should think of the rows being the readers and the columns being the cases. And I've color-coded these to be disease cases and non-disease cases, and the picture being all filled in is a fully cross study design. I'm going to remove those color codings so we can declutter the ideas. And I'm going to talk about a split plot study. These two pictures demonstrate a split plot study where we split the readers into two groups, and we've split the cases into two groups. And the first group of reader evaluates the first group of cases, and the second group of readers read the second group of cases. So we've just eliminated half the data to be collected. Think about that from a project manager point of view, not having to collect half of the data. Sounds good, but what are the price you pay? What is the price you pay in terms of statistics and variance? And that's what I'm going to show next. The nice idea here is the fully cross study can be pretty burdensome because it can add a lot of reads for each reader and a lot of reads total, whereas the split plot study allows us to reduce the burden on individual readers. That's one of the real important pieces here. And of course, you reduce the number of observations, you're saving time, you're saving money. And this work has been published. I refer to it as generalized analysis methods or treating arbitrary study designs, and the software I mentioned already can treat this kind of data. And now let's explore some different study designs. Here we have the example I already showed, where we have two groups in the split plot study. And I've already talked about that, but we could carve it up into 3 groups or even 4 groups. You can see with each increase in the number of groups, we have less and less data to collect. Now, how does that impact us in terms of variances? That's what I'm going to show. But you can also think about a fully cross study design that just has half of the data. Kind of like the same amount of data we collect in the true group example, only we don't even collect half the cases. It's fully crossed. The other fully crossed data to consider is just collecting everything so that we have these two comparators against our split plot studies. And then there's a last study design worth discussing because it will exemplify or highlight why you want to compare readers across modalities. So here we see the first group of readers evaluates all the cases in the first modality, and then the second group of readers evaluates all the cases in the second modality. So these readers are unpaired across the modalities. So remember that the framework I showed decouples the variance components from the study design. That's the key. I'm going to show you results based on the simulation that I didn't go into to save time. And these are just the numbers related to that model. Let's get to the results. So here are those 6 different study designs, a tabled set of results. The number of readers here is how many I'm considering for each of these study designs, the number of patients likewise. And the thing that I'm really controlling is the total number of image interpretations. Because to me, I feel like this is one of the determinants of the cost and the time that it takes to run a study. So that's kind of the thing that gets controlled here. But also good to keep your eye on is how many interpretations does each reader need to do? Because that tells the study designer how much time they need to show up. How much time is the reader going to invest in giving their time and data? And then this last column is the statistical efficiency. And this is the metric by which we can compare these different study designs. We put the variance of the 2-block split plot study on the top. That's why its efficiency is 1. And we put all the other study design, the variance of all the other study designs in the denominator. So that if the efficiency is bigger than 1.2 here, that means that this study design is more efficient. It has the same number of interpretations, but the variance of the results will be smaller. Likewise, these bottom 2 study designs take more data, And actually, this bottom one is less efficient when we think about the statistical efficiency. That's real cost, real impact on the variance of the study. So I'm going to give you the takeaways from this. First of all, it's really easy to compare different study designs given the tools I've outlined so far, and some simulation and some modeling. Once you get those variance components, you could do this, you could put together this table yourself. Number two, when you don't pair the readers across the two modalities, you pay a big price. First of all, the statistical variance of your endpoint is worse. The variance is larger, but you've collected twice as many observations as in the two-block split plot study design. That just doesn't make sense. Why would you do that? Well, that's the whole point here of exploring these numbers so you can see the trade-offs that you're faced with. This study also required 12 readers. More readers, more cases, more observations, and more variability. That just seems all backwards. So that's takeaway number two. Takeaway number three is that for the same number of observations, split plot study is more efficient. So we can see same number of observations. This fully paired A had a lower efficiency. It needs more cases. Takeaway number four is you can be more efficient by splitting up more. Of course, you need more readers, and that's maybe a small price, maybe a very large price. Maybe you don't have a lot of readers that you can call on. And then the real reason, why is all this happening? Why does taking more splitting be more efficient use of time? Well, it's really about avoiding diminishing return. If you measure the same case over and over and over again, they're correlated. You're not getting as much independent information from the measurement number 5, 6, and 7 as you do for the first and second measurement. That's the idea of diminishing returns. So if you collect 3, 5 observations, that's probably enough. And I'm going to have some rules of thumbs coming up. And that, it's all about correlations in the data. The more correlated the data, the less impactful another correlated observations. That's why split plot studies are efficient, because we're getting in new data, new cases that are independent from the first set. And so I still, though, when I do these split plot studies, I still want to evaluate the performance of each reader. And so for RLC studies, my rule of thumb, just me, my rule of thumb is that you need about 20 cases per class. So 20 disease, 20 non-disease, 20 cancer, 20 non-cancer. For each reader, in order to evaluate their RLC curve, their area under the RLC curve. And I think I probably am running a little behind now, so I will speed up a little bit. So, and I also feel like you need at least 3 readers per case, because you need to estimate a variance. And if you do less than that, how can you estimate a variance? So this is some literature kind of giving more math behind that. And the idea is more groups, less variance. All right. This is the study that I did comparing digital mammography to screen film. It was a big study, the original DMIST study, digital mammography imaging screening trial, 42,000 women, 1 reader per case though. This was not really able to suss out and estimate reader variability. Whereas our study, the study that I did, the Viper study, had 20 readers per study. It's actually 5 readers per case in each of these modalities. And when you start doing multiple readers per case, that's where the number of observations I collected started approaching the number of observations in the study itself. And the study explored different levels of enrichment, and as well as 2 different kinds of study populations. So again, the modality is digital mammography versus screen film. Past performance is detection. The readers are Mammography Quality Standards Act certified readers. And the cases are women with dense breasts. This is a very challenging subgroup. And the reason we chose that subgroup is because the DMIST study showed a very large change in performance. The original plan was to do 2 studies, 1 screening, 1 challenge. I'm going to explain what this means. The challenge study eliminates the easy non-cancers, and that's all based on the scoring system that they use in mammography. They have a scoring system that allows, that asks the radiologist to give us a quantitative or at least a qualitative score on for the patient. So we get rid of the easy cancers, and that makes it a challenge study, changing the characteristics of the population. We're going to use a split plot study design that allowed us to get 5 sub-studies instead of 2. That's the money savings right there, 5 sub-studies instead of 2. So in other words, I explored 3 different levels of prevalence in these 2 studies. Actually didn't have enough for the lowest prevalence in challenge studies. But let's take a look at what that means. So 20 readers, 716 cases. The cases break down as cancer, non-cancer BI-RAD 0, those are the hard ones. Non-cancer BI-RAD 1 through 3, those are the easy ones. And the readers are split into 4 groups. And we're going to get this as one of the study designs. This is the study design of the moderate prevalence, but trying to honor the distribution of normal cases, where there are thankfully a lot of patients that show as normal and are easy to identify. These are all the green ones. Those patients get screened, sent home, told to come back in a regular interval. Then there's the cases that are challenging. There's not as many of those, and they're challenging because they were scored by BI-RAD 0, but they don't have cancer. And then over here on the left are the cancer cases. I hope you were saying, wait, that's a lot of cancers. Yes, that's because we're already enriched at a level of 0.29. These are the 5 different study designs shown as these study design images. So you can see from the top to the bottom on the left-hand side, we have fewer and fewer normal cases relative to the cancer cases. That's the change in prevalence. And similarly, on the right-hand side, we see the change in prevalence. But now we've gotten rid of all of the easy cases into the challenging studies. These are some basic ideas on study design. Readers could participate in more than one group because the case sets were independent. The sub-study involved 2 sessions where they read with the one modality in half of the cases and the other modality in the other half. And then after a month or so or longer of a washout, they came back and read the other cases in the other modality. I already showed you the scoring system was 2 steps: do their recall decision and then a ROC curve score. And I also pointed out that there are resources for the instructions on how to score. Here's the data. It's a lot of things happening in this plot, but the key takeaway is all the ROC curves are overlapping quite substantially. The performance really did not change as a function of prevalence. And you can maybe see these cross points. Those are the reader averaged operating points. Those have a little bit of difference over the prevalence, and that's to be expected because decision-making is affected by prevalence. But you should really appreciate how much variability there is in the binary recall rate in these studies. We get radiologists that call almost all patients back, recall almost all the patients, and there's some radiologists that only recall a small portion. And you can see that the prevalence here is mixed everywhere. So it's not, these scores are not really strongly driven by prevalence. And this is where DMIST is. That is a very low prevalence study. And you can see it has the highest specificity of this entire population here. And that, again, is related to the prevalence. So in the big picture, prevalence does drive the operating points, but not so much the ROC curve analysis. I don't want to spend time on this looking at the clock, but this was the challenge studies. You can see the ROC curve is closer to the chance line. We have radiologists that are actually operating below the chance line because that's how hard the study was. The women with dense breasts, it's very hard to find the cancer in those images. And so they're worse than guessing in these observations. So this is the real punchline of the study. And I'm going to go through it one at a time, a lot of data in this figure, but we're starting out with the idea that we have 20 readers. We're considering 2 studies. The study that we did is this column right here. The study that we could do a different kind of study design, a fully crossed study design. They're both very low, both low prevalence, I wouldn't say very low, and very close in prevalence. And I want to start by showing this is kind of the control number. There are 308 non-cancers in the study, but because of the split plot nature, the split plot only has 154 non-cancers per reader, whereas the fully crossed, every reader has to read every one of the 308 cancers or non-cancers. Now looking at the number of cancers, this is where the power really comes in. For the split plot study design, every reader only reads 20 cancers, but there's 80 cancers total in the study. In the fully crossed design, every reader is reading 30 cancers, and every reader has to read the same 30 cancers. So we only have 30 cancers in the study. And that's what's going to drive the difference in the standard error. So in the split plot study, we have a standard error of about 0.02, whereas in the fully cross study design, there's twice as much uncertainty in the result, even though it has about twice as much data. So that is the revolutionary idea for me that I learned doing this work, was the split plot study design really has some efficiency opportunities. We see that bottom line again had lower variance with fewer observations. Lower variance with fewer observations. That's the punchline. So all this is in this paper. It was published in 2019. I just want to point at my software as a resource, and it's on GitHub as well as it's an R package on CRAN. This is the Java version, which is a user interface that is easy for non-statisticians compared to the statistical software. The hardest part really is formatting the data to be ingested into this analysis method. This is what the GitHub page looks like. You know, GitHub is great for getting version control and collaboration and issue tracking. The features of the software is you can size the studies, analyze the studies, and produce the ROC curves. There's a couple of nice wiki pages that discuss how to adapt data to do a binary analysis, sensitivity by itself, specificity by itself. And there are, in the wiki, also links to data packages. I think this is a really useful thing to know. These data packages, and I'm trying to think, I think I have something pulled up. Share, yes. So instructions for the numeric score. This is the actual page. This is what the landing page of the wiki looks like. You know, select the data sets, and there's 4 different data sets. And the key is that there is all the data, all the analysis methods, all the scripts, so that you could follow the calculations, create the figures that are in the paper, and then use those scripts with your own data to replicate the analysis and with your own data. So I hope that proves to be a useful tool. Wrapping up here with a summary, you know, I walked you through reader studies and the imaging modalities. The key is that the clinician is in the loop in these studies, and you have to start dealing with reader variability. The reader studies are a healthy portion of my review and my division's review responsibilities, as a lot of these algorithms and imaging devices by themselves are really only useful in the hands of the clinician. That's why we need to see performance in the hands of the clinician. And these MRMC analyses are not trivial. You need to account for reader and case variability and the correlations. The framework allows you to do sizing studies to weigh the trade-offs of practical issues and variances. And then the real punchline was that split plot studies can be quite a bit less burdensome than fully cost studies. I'm going to skip the summary of the Viper. We just talked about it. Hopefully you remember it well enough, and just point at some current work and future work. Data like this, where you have an image and you have different regions, it's called nested data. And we just published work that would treat that kind of data. We are working right now on quantitative measurements. There's a guidance document with quantitative imaging in the title, so just search on that and you will find the guidance document about quantitative measurements. And then here, the real emphasis is about reader agreement, because we're going to evaluate the agreement of an algorithm with some expert, but we're going to need some baseline performance, that being the expert with another expert, as just so that we have some context for what to expect from the algorithm, the reader agreement. Hopefully that sort of paradigm will be useful to some folks in this group. But with that, at least finished with 5 minutes left. I hope people have put questions in the chat. And also, I think Joe and Elo would be happy to receive questions by email. The way we did this before was I get all those questions and then I write up answers, and then I have to get clearance from my FDA colleagues, and then we will post all of that onto the web. Joe, how do you want to go?
Well, first of all, I want to thank you for this fantastic talk and overview. Maybe I call on some of the people who put questions in and see how much we can do in the last 4 minutes. Shailesh Konjeti, do you want to unmute and ask your question?
Thank you, Joe. Thank you, Brandon. Excellent talk. Yeah, so very much needed. My question is in the study efficiency calculations, right? So when we do multi-panel, multi-expert panel ground truth, right? Sometimes in the split plot designs, you end up having to truth more cases, right? So shouldn't we consider that also in the efficiency calculations?
So you certainly have the number of cases as one of the parameters to change. And you could put a $ for every one of those elements and use that to make your decisions. And definitely that's part of the balancing act.
Perfect. There's a question from Marcus Herman. Marcus?
Hey, Brandon. Thanks for this fantastic talk. At the beginning, you mentioned that one of the main questions that you get is the number of cases that should go into a study. I think you nicely highlighted in one of the previous slides how the challenge, the difficulty of the individual cases also, of course, affects the performance of the reader. So now, to me, these are two main parameters, right? One is the number of cases that you include in the study, and then how challenging should those be. And you've demonstrated that you may get very different results in the performance of a reader, of course, depending on how challenging the cases are. Could you maybe comment on this? What would be the optimal ratio between easy cases and hard cases, and maybe, what's your rule of thumb?
So certainly I don't want to answer this as a FDA kind of guidance answer, but what I have seen is that when you're comparing technologies, you can get away with a little bit more, call it disturbing of those distributions. And so it's a little bit of judgment. You want to see what happens in these different subgroups, and so you want to include them in your study. But if you, the results I had with the Viper study, the comparison of the two modalities, the results didn't change when I used the challenging cases compared to something honoring the prospective clinical population. And I think that's the idea. It's always a balancing act of all the goals you might want. And I find that the ROC studies do a decent job of, especially when you're comparing two modalities and you use the same data in both modalities, because then it's not like one technology had the easy cases and the other technology had the hard cases. As long as you give the same distribution to both technologies, the new and the old, then at least it's a comparison that is not as fraught as if you had different cases. So I think you can, from a research point of view, get away with what you can pull together. And then obviously, in the FDA regulatory setting, you'll want to have that discussion with the FDA, so that you don't do a study that that won't be acceptable. And we do all that stuff as a team at the FDA during the discussion from the manufacturer and from the whole team at the FDA. So that's a judgment call.
Thanks,
Brandon, unfortunately, we're at the top of the hour. I just wanted to remind everyone, if you're not a member yet, please consider joining PyCC. Here's the web address, and it's just basically a click of a button. And as a brief announcement, there will be a follow-up, which will be a 2-hour online, probably a hands-on session. You see the title here, again with Brandon Gallas, maybe with another scientist from within the agency and support. So please look out for that. We're still trying to schedule that. But with that, I thank everyone for joining, and the recording as well as all the material will be available on the website as well. So thank you very much, and I hope to see you soon.
Thank you, Joe.